Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am absolutely delighted to be joined this evening, or this morning, by the fabulous Dr David Saperstein, who has over 20 years of experience in diagnosing, treating and researching many conditions, including Ehlers-Danlos, PoTS, other dysautonomias, MCAS, post-vaccine symptoms, and now, of course, we're adding long COVID to the list as well. So hopefully we can join some dots together. So thank you so much for joining me today.
Thank you for having me.
So it's an absolute pleasure. To begin with, would you mind just introducing yourself a little and what it is that you do?
Sure. So I am a neurologist, and as you mentioned, I've been doing this for a number of years. And up until about 6 years or so, my focus was pretty much on more typical neurologic conditions with a focus on what we call neuromuscular disorders, so problems with nerves and muscles, peripheral neuropathy. And in the course of doing that, I worked a lot with a condition called small fiber neuropathy. And so nerves can come in different sizes. So the neurons or nerve fibers are basically like wires. They're small, medium, and large, and they each serve different functions. And over the last many years, it became more and more apparent that there were people who had problems with exclusively these so-called small nerve fibers, and it caused many problems that were falling through the cracks. You'll see there's a theme, and it was the first for like people who were dismissed as having psychogenic symptoms or not serious symptoms, or because the quote unquote standard tests, the regular tests that we would use, weren't showing anything. So typically we would use something called nerve conduction studies, EMG studies. We use electricity and send a little current across nerves and measure how well the nerves carry that. And that works for most neuropathies, most nerve problems, but the problems that are restricted to the small nerve fibers wouldn't get picked up by that. And then many years ago, people discovered that we could do skin biopsies where you take a little punch of skin and process that in a very specialized way and actually be able to see that the small nerve fibers were damaged or decreased in number. And it led to basically a huge change in how we understood things. So we were able to diagnose these conditions and realize that, hey, this was a potential explanation. And a lot of folks who are coming in with not just numbness and tingling, but fatigue and dizziness and lightheadedness, because small nerve fibers play a role in sensation, but they also play a role in the autonomic nervous system, or play important roles. And, dysautonomia, for all of you with long COVID, I'm sure that little buzzword has been coming around. And so a lot of the patients I was seeing were having dysautonomia, which led me to start doing testing of the autonomic nervous system and start seeing more patients with PoTS, postural orthostatic tachycardia syndrome. And then it led me to start seeing patients or appreciating that a lot of the patients I was seeing had something called Ehlers-Danlos syndrome, a condition, genetic condition of their connective tissue where they were more flexible or hypermobile, and realized that there was this nexus between EDS and small fiber neuropathy and dysautonomia. And then, the more I learned about that, the more I started seeing those patients. Again, a group of patients who, by and large, were being told that, all their tests looked good and there was nothing to explain their problems, and it was likely just anxiousness or other issues like that. And we could realize that there are a lot of people that we were able to definitively diagnose, and more importantly, have ways to help them. And then I had to learn about a lot of these different conditions because they impacted these disorders so much. And another one that was very important is something called mast cell activation syndrome, or dysfunction of mast cells, which I think has come up on previous podcasts, or probably something we'll go into more detail on. And again, that's in that whole mix. And, I've been working on that in the last several years. And then, lo and behold, a lot of these conditions turn out to be important facets of long COVID. So obviously before COVID, there were no long COVID specialists. And then, certainly now there are people who work with long COVID patients, and they're, a heterogeneous group. Some of them are specialists who are focusing on certain parts of it. So, their neurologic symptoms are very common in long COVID. So neurologists are looking at it and trying to figure out why that is. GI symptoms are very common. So gastroenterologists are looking at that. There may be blood clotting issues, so hematologists, joint issues, so rheumatologists. But it's the same or similar problem to the whole EDS, dysautonomia, small fiber neuropathy, mast cell, is that if everybody's in their bunker, they may be missing the larger picture. So I like to feel that clinicians like myself who have been working with these diseases before COVID are already, in the mindset of realizing that there's complicated issues and they're interconnecting, and you need to cross disciplines to get the full picture. And you need to realize that a lot of standard tests, quote unquote, are going to be not helpful, are going to be normal. And you have to dig for the answers. You have to listen to what your patients are saying. And that was, I guess, a very much long answer to question, and tell you a little bit about myself.
It's fine. It's absolutely fascinating. And it's another reminder as well, isn't it, that, all of these conditions, they all existed before COVID, and before long COVID came along. So, there is stuff out there about them already. So somebody who, once you realize what dysautonomia is, for example, that was a big thing for me, realizing kind of what it was and what it meant. And then, more importantly, what I could actually do about it. Because like you say, a label is only useful insofar as you can then treat it, isn't it?
Yes.
But also the way that they all interplay is absolutely fascinating, isn't it?
Oh, absolutely. It's been, it has been and continues to be, a process of, I'm always learning new stuff and interacting with other colleagues who come at it from different perspectives. And that's been invaluable. Physicians spend years and not just with training, but then years of their careers, by design, focusing on a very small area to become expert in it, which is obviously important and valuable. But then I spent years specializing, and then sort of spent the last few years despecializing, but not really. I mean, but broadening, and, for a neurologist to be thinking about, gastroenterological issues or hives and allergic reactions. I mean, the average neurologist would think that, that's not anything that should be or would be in their lane. And, my current work, I don't see how I could really do it without, crossing the lanes, because there aren't these nice, clean lines in any given patient. Well, those symptoms are dysautonomia, those symptoms are mast cell, those symptoms are a gastroenterological problem. They overlap, and certainly there's roles to play, for gastroenterology specialists and other, allergists and so forth. But then a lot of them, are just in their nice, cleanly defined bunkers, and it doesn't matter who the specialist is, but you need somebody who can kind of put these things together, and not afraid isn't the right word, but sometimes not be afraid or concerned about what the symptoms are, what the issues are. Just the patient doesn't care from what specialty help is coming as long as they're getting it, and that's the key. I'll have patients referred to me from a different specialist, and they say, well, like from an allergist, say, oh, you need to see Dr. Saperstein because those symptoms are dysautonomia, and I'll listen to their symptoms and say, I think treating your mast cells more aggressively is going to be the best way to help what's going on. But they just came from, theoretically the mast cell doctor. So again, I have a much broader toolkit than I used to. And, the $1 million question is the toolkit that we use for these disorders, dysautonomia, EDS, PoTS, mast cell, is that the right toolkit, for long COVID? I mean, that seems to be the case in a large number of people. And, but, do we need slightly different tools? Is that not the whole story? Is it as simple as saying, people with long COVID are developing issues that we've seen before COVID? So we've seen people develop PoTS and dysautonomia after a virus or of other kinds, or after other triggers or mast cells being triggered. Again, I think so, many think so, and we always, again, need to keep our minds open to, other things. The COVID virus has proven to be a very formidable foe and very unique compared to most other things we've faced, certainly in recent years in medicine.
Yeah, and this kind of like overview that someone like yourself has, where you can see all of these different sort of sub areas, if that's even the right word, but also having the specialties within those kind of sub areas, I think is maybe quite, well, useful, I guess, is maybe the right word.
Yes.
Yeah, it's interesting you were talking about the sort of the different conditions, I guess is the right word. So, things like your PoTS and your dysautonomia and your MCAS, and, all of these conditions are different, and, everyone's experience of them is so different as well, and then there's obviously all these links between them. And how do you differentiate between them? And I suppose also, is that important to do that? Because, I mean, again, thinking about my own experiences, to start with, it was impossible to see the wood for the trees because there was so much going on. So do you need to kind of, is it to sort of find a way in, maybe, to start with?
Yes and no. um, so obviously the best starting point is to start at the beginning and figure out what is or what isn't going on. And, for a lot of individuals, there were issues present before COVID. Not always, but so the first step is we see that, and I think one of your previous guests was talking about that, where she had stuff going on, and then COVID sort of triggers, and we see that, and so we're always starting childhood, and we may find that people have issues that suggest that there was some mast cell disorder issues. It wasn't a big deal, but it was like, yeah, people always had a sensitive stomach or reacted to certain things or would get hives or rashes easily as a child. People may have been prone to lightheadedness, nothing that got in the way of things, but or even some of our patients, fainted when they were younger and just like, well, I was dehydrated, or it got attributed to different things, or childhood history of migraines. And then, they functioned very well. They lived their lives. They did what they wanted to do, what they needed to do. And then something happened and things changed. And certainly COVID infection or COVID vaccine can be that something that flares these diseases. We're not quite sure why. And, there are other individuals where you can't tease out any prior, there's no evidence of it. Does that mean that they have a different story or a different way of coming to it, or they had just a much more subtle case? Again, that's where we're not sure, and we certainly see variability, heterogeneity in this. So like I said, I mean, my approach is two-pronged. Again, rounding up the usual suspects, as we sometimes like to say, because we often find those. And again, is there an underlying connective tissue disorder like Ehlers-Danlos syndrome? Because then we may treat that and different ways, or that may lead us to look for other complications or other problems. Is there dysautonomia? And if so, defining that in the sense of, is it PoTS? Is it something different? What sort of subtype of PoTS is it? Because again, that's going to potentially help us, figure out the best ways to treat that. And again, does there seem to be a big mast cell component or not? And so each person, how we tackle it is going to depend on a number of factors. I always tell people I think of it as a sort of a control board with different knobs. I know I'm still analog. And, we know that turning one or more of these knobs potentially is going to be the key to helping, but we don't always know. And so, we could just start turning knobs, but based on the certain picture that person's presenting with, we say, well, it makes sense to start here, and we start turning a knob or so, and we may need to turn that back. We may need to try a different tactic, but it's zeroing in on how to optimize, how they're doing, getting things under control. And then, like I said, just always realizing that we don't want to get tunnel vision, always realizing that with post-COVID, we may need to add some knobs to the control panel. So far, again, most patients, it seems to resemble dysautonomia, and mast cells seem to play a role. But again, it's not always the case, and lots of work continues to go on to get to the bottom of long COVID.
Yeah, I love your control board analogy. I've heard a lot of people sort of describe it as bits of a puzzle, and it really is, isn't it? It's trying to slot it all together, and no two patients are ever going to be exactly the same, are they? I guess. We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us.
Yeah, it's one of those things where, in a big sense, a lot of them are very similar, but obviously, the details are important. So that's the good news, is that, it's very similar, or the themes are. So it makes it's important that they are, because then it's manageable. And so, as I say, when I first started doing this, I sort of segued from focusing on other diseases to seeing more and more individuals with PoTS and EDS and mast cell. And at the beginning, I'm like, what am I doing? Why am I neurologist dealing with these issues? And then I realized two things: is like, well, now having done this a bit, I've realized I already, have a little list with my new patient, and I'm like, all right, I know that I'm going to ask them about these symptoms because there's a very good chance we're going to have them. And I'm like, oh, I've got my approach. I've figured it out. And then I realized, number two, well, very few other people are doing this. So, I figured it out or started to figure it out, and no one else is. So I'll just keep running with this. And so again, it's nice that a lot of patients will have similar themes, and it's reassuring for them, because they've so often been told that their symptoms are odd or crazy, or they're crazy, or their symptoms, they shouldn't be having those symptoms, whatever that means, right? They are. And so I think it's certainly reassuring and a relief to the patients to hear that. But everybody's different. We have a new medical assistant who started with us, and so she's in training. So we brought her in, yesterday. I'm like, okay, start by sitting in and with these patient encounters and seeing. And we had a patient first thing in the morning, and then the next patient, I'm like, oh, this will probably be pretty similar, and it was very different. So again, everything's similar but different, which is great. It keeps it exciting and challenging, and But you don't want everything to be too exciting or challenging, because then you don't know what to do. Again, the good news is we have a framework, a scaffolding of where to start, and then exactly it's always going to be customized, for each person, or needs to be or should be.
Yeah, definitely. And and you mentioned some of these conditions, so things like Ehlers-Danlos, pre-existing POTS dysautonomia, MCAS, and then obviously long COVID, which may or may not be some sort of collection of all of them, plus or minus other things. Are you seeing any kind of common themes between them? I know that's probably a really wide open question.
Yes, I mean, has been pointed out, or people have read about and talked about, in long COVID. Number one, there's a lot a lot of different symptoms that can happen. That includes, fatigue, brain fog, dizziness, heart racing, shortness of breath, chest pain, gastrointestinal problem, numbness, muscle aches, headaches. Don't want to leave anything out, but those are common ones, especially coming on abruptly in somebody who's not accustomed to have those things. And again, the trouble that people run into, and seeing doctors and being in the medical system is, well, those, each one of those symptoms is what we call non-specific. So, I mean, yeah, there's many things that can cause it, but when you see many of those or most of those together, and they're coming on abruptly or coming on after a trigger, then again, it fits a pattern. And so, we're seeing those same sorts of symptoms that we see in long COVID, we see with, sometimes it's hard to know what to call these patients. Long COVID is easier because we can pin it on the COVID. I mean, if somebody develops POTS, post flu, we don't call them long flu, or we say they have POTS. But then the problem with POTS is, while there are some patients who, quote unquote, just have POTS, quite a lot of them have these other factors, whether they or their providers realize or they're not. They have mast cell activation and so forth. So some of us who do this call patients the trifecta of hypermobility and dysautonomia and mast cell, or there's these so-called pentad patients of dysautonomia and hypermobility and mast cell and GI symptoms and immune issues. And then there's even some people have added to that, and they have septad to add 7 things, or I mean, you could add it on and on. And again, the theme is that there's some thing about certain individuals, we think, who are genetically predisposed to potentially react poorly in certain ways. So we think that most people can get the flu or have COVID, and they're sick at the time, but then they come out of it without chronic, dizziness, lightheadedness, heart racing. And then we think there's something about people, some of them or many of them are these people with Ehlers-Danlos or other genetic issues that make them hypermobile, that they seem more susceptible to having these problems develop. Again, that's what we think, or many of us think. We don't know. We still don't know to what degree there is potentially an autoimmune issue. So, do these viruses, or particularly long COVID, or can it trigger an autoimmune response? And is that why there's dysautonomia and mast cell dysfunction and these other issues? And again, as I said, fortunately, research goes on, and long COVID has put a lot of wind in the sails of that research effort, because prior to that, while there's been research, it's been on a small scale and hasn't had a lot of attention. Another condition that gets talked about a lot is this MECFS, or myalgic encephalitis chronic fatigue syndrome, which again, for decades, individuals have been suffering from. And again, this same paradigm of seemingly post-viral or post-infectious, or at least, or some sort of an illness or injury serving as a trigger. And then, in recent years, there was the appreciation that a lot of patients with MECSF had dysautonomia, had mast cell activation syndrome. A good subset of them had EDS. And so it turned out that a lot of MECFF patients had these other conditions, which was great because then we could sort of break it down, as I said, and focus and treat those conditions. But not all do, and so a lot of people say, well, is long COVID just is basically ME/CFS being triggered by COVID, and again, it gets tricky because you have to give things names, otherwise it's too chaotic. But on the other hand, you need to be careful when you name something because you don't want to get too hung up in, I always tell people that the minute I think that I understand that things perfectly, then I need to be concerned because, you know, you need to have certain theories and you need to operate with those. And so when I'm in the office talking to a patient and explaining why I think all of this happened, I'll give them an explanation of a theory of how, mast cells do this and they're affecting your sympathetic nervous system in this way, and this is because of A or B. And I believe that to be true, but I also realize that, there's plenty of things that we believe to be true that, then a few years later we realized either, we didn't have the full picture or, it's not, some things about that are incorrect. And so you don't want to be paralyzed. And that's what I think happens. A good part of why a lot of patients don't get help that they need or diagnoses is that the doctors often, if they don't have all the facts, just feel like they can't proceed. So you don't want to be paralyzed by not having all the answers, but you don't want to conversely go off the rails and do things just sort of on whims or jumping around based on loose theories. But everybody sort of has to figure out where that happy medium is between being comfortable enough with the information we have and doing things that we initially think are going to help people without again guarding against believing our own propaganda to the point where we may not be open to better or different answers, or we're sort of get hung up on or stuck on things. So again, we give things names and then move on, but realize it's operationally how we discuss it amongst ourselves as clinicians, how we discuss it with patients, and then having that parallel, doing pragmatically diagnosing and treating people, and then thinking about how to improve that process to make sure we incorporate new thoughts or try to find new answers, if that makes sense.
We'll be right back. Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much. Yeah, it's this I guess it's a delicate balancing act between treating and helping people with what you do know and what you know works, while also being open-minded enough to sort of keep your ear to the ground for other stuff, I guess, isn't it?
It is, yeah. I mean, it's been a process for me. But again, I think a lot of physicians, they're used to being smart and having the answers, and they went through school getting good grades, they went through training, answering questions and having the answers, and obviously those are all good things and you want to have good answers for your patients. But then medicine is an art to practicing it, of balancing the science of it and the sound judgment of it, but then also figuring out how to help people. You're never going to have all the facts and all the information, so you have to be comfortable treating it.
Yeah, definitely. I mean, we're sort of talking about long COVID, I suppose, here, but also the whole breadth of everything else, because as we've just been discussing, it's all very much related. But, I mean, long COVID as a thing has only been around for a few years because, the virus itself is new. And as you mentioned earlier, we've also been seeing post-vaccine symptoms as a result of, well, the COVID vaccine. Are you seeing any kind of interesting patterns, I suppose, between the two of them compared to what came before at all?
I have. And so much has been published and written about, dysautonomia PoTS happening to individuals after COVID or after COVID vaccine. And there's not been, by and large, a distinction between PoTS, post-COVID or post-vaccine PoTS and PoTS from, not related to COVID or not related to the COVID vaccine. And maybe there isn't a difference, but I've been struck by the fact that the long COVID individuals seem to be different. And what do I mean by that? So POTS has a lot of symptoms, and again, everybody's different. And the two main themes are being lightheaded, particularly with being upright or standing, and getting racing heart rate. To me, quite often the post-COVID individuals or the post-COVID vaccine individuals that I've been seeing seem or a much more prominent symptom is racing heart rate. So they're describing my heart goes really fast and it's uncomfortable, and to a much lesser degree they're experiencing lightheadedness. And conversely, unrelated to COVID, the POTS patients I see traditionally, again, they're more noticing trouble tolerating being upright. But again, it's hard because there's subtle distinctions. They experience racing heart rate and so forth. And if you test it, if you do tilt table tests or other tests that we do to measure, it looks the same. Their test results have been looking similar as far as I can tell from looking at the literature and looking at my patients. And not everyone agrees with that, and other dysautonomia specialists aren't making that distinction. But again, that's something that I'm trying to figure out how to get a better handle on. But I've noticed that. I don't know what it means, but it's different. And it just may be that post-COVID is unique, and because we're seeing patients very soon after the onset of symptoms. I mean, one of the very negative or bad things about POTS is, again, how long it takes somebody to get diagnosed. So certainly as a POTS specialist, you're usually seeing people after they've kicked around, or they've been kicked around, or they've bopped around the medical system for years. And so maybe if I had spoken to them, within a couple of months of the onset, maybe they'd be describing their symptoms similarly. So maybe it's just more of, there's an acute onset phase, and then there's the more longer term. And since we haven't had a very long term with post-COVID yet, so that may be it. But again, I don't know what that means, but it seems to be different, and that's been part of the theme. And as I've alluded to, is that our tests aren't as good as we would like them to be, as good as we need them to be. So, I mean, our diagnosis of POTS is pretty unsophisticated by and large. You lay somebody down and stand them up, or you tilt them on a table, and it's like, what's your heart rate? What did it go to when you are upright versus when you are flat? We also look at blood pressure and so forth. And then it's like, if heart rate increases above a certain amount, boom, you're diagnosed with POTS. I mean, there are other things we can do, and in our practice, we use special ultrasound and measure blood flow to the brain that gives us some supplemental information that's helpful in some cases. But again, at the end of the day, our testing isn't sophisticated enough to make these fine distinctions. And again, nobody really knows. We know parts of it, of why POTS happens and why the different aspects, but in a given patient, we're never really sure how these parts come together. And it's definitely the same thing applies to long COVID. But so again, that's just an example of recognizing that dysautonomia is causing or can cause a lot of long COVID symptoms of fatigue, shortness of breath, anxious feelings, GI symptoms, temperature regulation problems, et cetera, just as we would see in a POTS patient. And so at least we're not just starting without any framework. We can at least say, okay, well, what would we do for POTS? And we do those things, and fortunately they help a lot of people with long COVID. But in the cases where people don't respond as well as they should, or aren't responding in the same way, again, that's where it's important to keep our antennae open to, well, there may be differences, and how could we be treating things or treating people differently? And again, it's still a work in progress. So the two things that I found the most striking is, one, how often dysautonomia and MCAS seems to be an issue in long COVID, but then the other is straight noting that the symptoms do seem different, and trying to figure out why that might be.
Yeah, that's really interesting, isn't it? Wow. So, I guess this is going to be another incredibly wide open question, but I would love to talk through some sort of management and treatment sort of options that you might offer or suggest to patients.
Sure. So, as I mentioned, if I'm seeing a patient in my office, I'll start by, figuring out, does it seem like, they had a pre-existing condition of joint hypermobility, of symptoms suggestive of MCAS or even dysautonomia symptoms. And then that blossomed or somehow got flared up. And then again, the treatment is going to be focused on the dysautonomia and the mast cell activation syndrome. Again, keeping the eye out, are there some of the other theories? So this is dysautonomia and mast cell activation syndrome, similar to what happens with other infections, with other triggers that those of us who have been treating diseases have been seeing for years. Or again, is there something different about the COVID virus? Is the virus having ongoing effects? Is there ongoing inflammation? And so again, much work has gone on and continues to go on, looking at cytokines and other things that we can measure in the blood. Are there these so-called microclots, small blood clots that are affecting small arteries and causing many of the post-COVID symptoms? And then one would wonder, if that is true for COVID, well, is that actually been playing a role in the patients we've been treating pre-COVID, the pre-COVID pandemic? Again, like I said, I definitely want to keep an open mind. And so if patients are an outlier, then maybe they need to be seeing a hematologist or somebody dealing with blood clotting and so forth. So again, we want to make sure we're not just doing a one size fits all management strategy. But in answer to your question, in my experience, most people are going to benefit, or it's appropriate to try treatments for dysautonomia and mast cell activation syndrome. So as other guests on your show have talked about, there's initial steps for POTS or dysautonomia, which are being well hydrated, increasing salt. I would add, getting adequate rest. Physical exercise, physical training is a component, but that's always a bit of a double-edged sword, or catch-22, is like, well, you have to be at a certain place. You have to be well enough to be able to do that. And sometimes, again, medications can help. Again, particularly with the long COVID patients where the heart rate is going really fast, it seems that that's being driven by some inappropriate overactivity of the sympathetic nervous system. So, using medications that can quiet that down and slow the heart rate. But then in my experience, most patients, or quite a lot of patients who have overactive sympathetic nervous systems, mast cell dysfunction plays a role. I was saying before, it can get really hard to make nice, clean lines between it. And I think, mediators, chemicals that the mast cells can give off, can stimulate the sympathetic nervous system and overactivate it. And then, but if your sympathetic nervous system is activated, well, then that causes, or can cause, mast cell activation. And so I think of it as potentially this feedback loop. And so oftentimes you have to treat both parts of that loop, because if you leave one side to its own devices, it can trigger the other side, even if you're doing all the right things in theory to try to treat POTS. If the mast cells are running loose, they're going to potentially keep flaring it up, or vice versa. If you're stabilizing mast cells, are doing things that should be good strategies for mast cell activation syndrome. If you've got a sympathetic nervous system that's sort of bursting out or doing things that flaring up, then that can do it. So the mast cell side of things, again, getting back to it can be very hard. We don't have the tests that we would like. So there are certain blood tests, there are certain urine tests where we can see that there's elevated histamine levels, there's elevated what we call mediators, other chemicals that the mast cells spit out. We can see that there's elevated levels of those in the blood, or there's elevated levels in like a 24-hour collection of urine. Sometimes we can even see that there's too many mast cells, like in the GI tract. If somebody has a scope or an endoscopy and they get biopsies, we can quote unquote stain those in certain ways and see that there's more than the number of mast cells that would be expected in the intestine and the colon and so forth. But a lot of times our diagnosis is sort of presumptive, just based on the symptoms. So if somebody's having a lot of GI symptoms, if somebody's prone to getting rashes, or their skin is sensitive, if they're sensitive to smells or scents or so forth. So a lot of times antihistamines. So again, I don't know what you have in the UK, but I mean, in terms of names, I mean, so like Zyrtec or Allegra or Claritin, fexofenadine or cetirizine or loratadine. And again, there are other brands, but these so-called second generation histamine blockers or antihistamines, or they block what we call H1 receptors, which is one of the more common receptors that histamine binds to. Mast cells release histamine, histamine triggers mast cells. That's a part of it, but there's a bigger picture to it. But some people respond very well to histamine blockers. And we find that for some reason, the dosing often needs to be higher than like a usual dose for these second generation antihistamines, which are usually non-sedating, is 1 a day. Whereas we find that twice a day sometimes seems to work better. And even though they're long acting and you quote unquote should only need to dose them once a day, we find that, again, if we do it twice, so we do 1 in the morning and 1 at night, and then we use so-called histamine 2 blockers like ranitidine or famotidine. And traditionally, those medicines are used to treat too much stomach acid or heartburn, because one of the roles, if you block histamine 2 receptors, one thing that will happen is you can decrease acid production. But there are histamine 2 receptors throughout our body. There are histamine 2 receptors in our brain. And we found that if you block not just the H1 receptors, but the H2, that you can get a bigger effect. So again, we may do a high dose of ranitidine or famotidine twice a day, 20, 40 milligrams of famotidine, for instance. And, the H2 blocker is interesting because they've come up in the COVID world. So both with treating acute COVID in terms of helping with that cytokine storm, which again, many people think has to do, mast cells play a role in that. And then certainly in long COVID, and then famotidine or these H2 blockers may play other roles in terms of interacting or affecting the immune system and so forth. And then there are mast cell stabilizers. So if somebody's mast cells are overly reactive, mast cells, their normal job is to be sort of the first line of defense against foreign invaders trying to get into our body. So they're stationed in our skin, in our nasal passages, in our airways, in our GI tract. There are quite a lot of mast cells in our GI tract. So a lot of GI symptoms, I think, stem from that. And there are medications like cromolyn or ketotifen that can help stabilize the mast cells. There's a supplement called quercetin, which no prescription is needed. It's a natural component, an antioxidant that's in fruits and flowers, and that can be a good mast cell stabilizer, although oftentimes the dose needs to be high. So, supplements may be 250, 500 milligrams, but sometimes that'll help, but sometimes you really see better effects when it's higher. Even though it's a supplement, it can cause issues. I mean, overall, all of these mast cell stabilizers are generally safe and well tolerated in the scheme of things. quercetin, the supplement, can interact with like thyroid medicine or other medicines. You always want to check with your healthcare provider, but that's something that, again, people can take. There are certain cocktails of using a histamine 1 blocker, histamine 2 blocker, or some one or more mast cell stabilizers. And that may not be the whole story, but some people find they start with that, and it helps with GI symptoms, helps with brain fog, helps quiet down the sympathetic nervous system, and then people can build from there. But so again, I usually find that something to blunt the effects of that sympathetic nervous system are going to at least help people feel better. I mean, it's the part of your body that's telling you something bad is happening or preparing you to flee or fight. If that's just always or frequently being activated, that's going to, in and of itself, just be very exhausting and uncomfortable. And quieting that down could go a long way towards that. And I've talked about medications and other things, and there are other ways. So there, behavioral ways of balancing the autonomic nervous system and quieting down the sympathetic nervous system. So meditation and other ways, and there are certain programs that many patients benefit from, these so-called neural retraining programs, where they can sort of help. If your sympathetic nervous system's overactive, it's triggering, but there's not wolves at your door, so you don't need to flee or so forth. Then it's kind of like a broken alarm. That alarm's constantly going, but there's no fire. It's a fire alarm. There's no fire or so forth, and it's a broken alarm. Then obviously you'd like to fix that alarm so it shuts up. But until or unless you can do that, then at least realizing, okay, there isn't a danger. This isn't an alarm that I need to respond to, and then figuring out how to block it out, so to speak. And so that's what a lot of these programs are, and there's different ways of doing that. And so sort of coexisting with these signals. I mean, it's not optimal. We'd rather turn them down or figure out what's driving them. And sometimes we can, and everybody's different, and we're not sure why we have more or less success. But again, getting back to that toolkit, you just want to have as many strategies as you can, and at least try to help people get better. And we talked about how everybody's different. It's always fascinating how, in one patient, we tweak just a little bit and they do wonderfully. And then other people, it's a lot harder. But, sometimes you think you're going to need to fix all of these problems before you're going to get them doing much better. And sometimes, to your pleasant surprise, you don't need to. And many people do get better. And I guess we don't talk about that enough, I don't think. And so, like, as you said, we're only just a few years into this, but people with long COVID can and do get better with just the passage of time, without anything specifically be going on. Again, we don't know how to predict. We don't know who. We don't have the tests or the algorithms that we would need. We don't want to just sit back and count on that, but we don't want to lose sight that there's hope there too, that people can and do get better.
Yeah, I think that's a good thing to really bear in mind, because I think we kind of only hear the bad stories, don't we? And we in support groups and everything, it's all the people that are still unwell.
Yeah.
And I think it's very easy to lose track of the fact that actually there are people that have got better. They just don't want to hang around in support groups anymore.
Exactly. Yeah, that's the support group phenomenon.
Yes, yeah, absolutely. I think you mentioned research a little bit earlier, and I would love to just know if there's anything ongoing that you think is particularly kind of interesting or useful in this field, whether it's stuff you're involved in yourself or otherwise.
Yeah, I mean, I think one of the best things, if you will, about research is that it's looking at different avenues, which again is always important, not to have all your eggs in one basket. And so, as is often the case, we start out learning pieces of the bigger picture, and then we have to see how those puzzle pieces fit together. But things that have been interesting is looking at people's response, doing exercise testing and seeing how their oxygen uptake is and what happens, how their metabolism is, and some groups that have been looking at that and finding some interesting things in long COVID, and finding that certain treatments or medications can at least in the lab setting help that. It's been interesting to see, I guess, certainly with my background and doing a lot of work with small fiber neuropathy, is seeing how prevalent small fiber neuropathy is in people with long COVID when you test for it, and what role, again, that seems to be playing a role in terms of the dysautonomia. The small nerve fibers just play critical roles in regulating our autonomic nervous system. In small fiber neuropathy, there had always been this question of what component or to what degree autoimmunity, the immune system turned against the nerves, what role does that play? Certainly research on that continues to go on, because we have medications, we have strategies for targeting dysfunctional immune systems, dysfunctional in the sense of they're being overactive or turned against us, and if we can treat that, then that may be a very effective way of helping people. I think just continuing to try to figure out what's going to be useful in terms of understanding this and treating people, and what's noise. There are many different blood tests that can be looked at, and cytokines and so forth. And I think those are flashy and get attention. And again, I'm not dismissing the significance of those, but again, only time will tell which of those are going to be important and are going to be valuable for helping us understand diagnosis and treatment. And so that's sort of what I look to in the research. Research that, if I had my wish list of hoping for answers to, like I said, figuring out ways, and I'm still scratching my head, and hopefully others will have ideas, of, as I mentioned, figuring out, is long COVID dysautonomia different from other forms of dysautonomia, and how we can sort that out, and how that would change or might change how we treat it. And then maybe we'll find better ways of breaking down dysautonomia in patients who don't have it from COVID. So there's always heterogeneity there, and maybe there are people, if tachycardia, racing heart rate, is a bigger symptom, why is that? What is that telling us? And so maybe there's better ways that we should be treating not just certain long COVID patients, but certain PoTS or dysautonomia patients who have their PoTS and dysautonomia for other reasons.
Yeah. I mean, it's fascinating, isn't it? I'm not a scientist or a medic in any sort of a way, and I feel like I have my research wish list. So I can't imagine how someone who actually understands all of this stuff like yourself must be so much bigger.
I mean, as you can probably tell, my approach would be to take the big problem and just try to break it down into recognizable and bite-sized pieces, and sort of, tackle what we can, and then continue to try to figure out how to tackle the stuff that doesn't respond like we hope it would, or that we don't understand as well. And I've found that to be a useful strategy for dysautonomia, for mast cell, for EDS writ large. And again, I think the same applies to long COVID. I guess a question I often get asked is, advice for patients and how to find clinicians who can help them, and that is hard, because it's the people who deal with this sort of thing. We come in different boxes and shapes and sizes and labels and settings, whether it's in a private practice or an academic center or whatnot. And so I think social media, it gets a lot of knocks, but I think it's been a valuable way for individuals to learn about these issues, and learn about who potentially can help. And again, long COVID centers are important and valuable, but they're not all the same. And like I said, some of them are just major medical centers that have just run the patients through. And if you have GI problems, you'll see the GI doctor. If you have neurologic problems, you see the neurologist. If you have breathing problems, you see the pulmonologist, et cetera. But then it's that same old problem of each specialist just looking at their prism with their tests, which may lack the ability to see the full picture. I mean, obviously, again, there are going to be patients who have a heart problem, who have a lung problem, so it's important that we don't, again, assume it's dysautonomia when it's a more distinct problem, and that we need those providers. But all too often, our experience has shown that a lot of individuals, again, it's just another circumstance where they get run through the tests that the cardiologist knows to run, and everything's normal. Their MRIs are normal, and their neurologic examination is normal and whatnot. And so you need someone, whoever that is, or whoever that team is, to sort of put the pieces together. And again, nothing's perfect. Social media is not perfect, but I think it does provide a forum for people to try to get that information.
Yeah, absolutely. Well, thank you so much for joining me today. It's been an absolute pleasure chatting with you, and sort of sharing your experiences of, the past 20 years, actually. I've learned so much, and I hope everyone listening has too. So thank you so much.
My pleasure.
Thank you so much to all of my guests, and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch. I'd love to hear